Thank you. So we move on to the uh, talk on diabetic tractional retinal detachments by Carlos, and we look forward to this. This is, again, a very difficult situation we face.
So, good morning, everyone. I'm Dr. NASOL from the Philippines. We have a saying in the Philippines, rice is life. So, as we can say, I'm dealing with 80% of the diabetics in cases in fellowship and in training. Again, so let's divide the section into three cases: preoperative updates, intraoperative updates, and postoperative updates. So let's start with preoperative. Usually preoperative, we do give your bevacizumab or what you call a anti-VEGF 3 to 4 days prior to your injection. Use it for at least 2 weeks. And before you do your surgery, you have to ask your next surgeon, do you have a buckle? Do you have a tube? Or is it patient going to undergo any bleb surgery? So if this patient is going to undergo bleb surgery, do inject it inferiorly. So to give you a preoperative thing, uh, the anti-VEGF shrinks neovascular complexes. It reduces bleeding. You can use your bevacizumab or your ranibizumab at least 3 to 7 days pre-op. As an update, it produces 40% less hemorrhage and it cuts your OR time by 25 minutes. Ranibizumab edges over bevacizumab for faster regression, but it's hard on the wallet. Timing is usually at least 7 days, but not more than 14 days. We now go on to wide viewing systems. With the wide viewing systems now, we have the choice of putting your biome, you can use your resight with the help of your 3D system as well. You can use your wide viewing systems. As you can see here, you can use lesser light for lesser toxicity, and then you can see at least the edges of the retina. You can use your gauge 25 with your 3D system, and then you can do your surgery quite well. The role of wide-angle viewing system would be to enhance visualization. You can use your contact lens, you can use your indirect lens, and usually wide viewing systems will have 20% better peripheral break detection. You can use also your chandelier, but therefore, in wide viewing system, there's a pitfall that usually glares will happen in when you're dealing with macular traction. Next, what I love is small gauge vitrectomy. With the advent of the newer vitrectomy systems, you can then just use your gauge 27 with the new 20 K cut rate. You can do it safely. You can go inside the retina. But the pitfall for this is usually when you have larger hands, the vitrector tends to bend on the side, and when you're doing your periphery. What it is good about it is there's not a lot of vitreous traction when you're using the gauge 27. It takes time because of the smaller gauge, but it's relatively safer for the patient. Just make sure that your patient is just dealing with a simple vitreous hemorrhage. The common pitfall for the gauge 27 is usually that gauge 27 clogs when you have tractional retinal detachment. You can go in closer to your traction, but definitely clogging the gauge 27 will always be a hindrance to your case. So as a tip, you can go for a hybrid. Hybrid meaning always prepare your gauge 25 as well when your gauge 27 just clogs in. How do we deal with intra-op, core vitrectomy, and truncation? So again, I'm using now gauge 25, hypervitrectomy. You can do your vitrectomy, again, 20,000 cut rate. You can go down to the retina. You can go down to periphery safely. And then from there, you can see the movement of the gel or the movement of the vitreous will be definitely slower. You can go now to your interface vitrectomy along with gas, safely moving without causing any traction retinal detachment. So the technique of this is you have to cut at least anterior and posterior before you go inside. Triamcinolone staining is a must to see the residual vitreous. And I was talking with Dr. Berrocal a few days ago, and You don't have to remove all the tractional membranes. You can just move, in patients who have chronic diabetics, just create a small little nick at the center in order for them to ambulate. It's not for them to read, but for them to ambulate. Again, as we said, skimp on precision in those chronic cases. The goal for this is not for them to read, but for able to them just walk around, see what they're eating, and then just recognize little bits of shapes. So now we go to segmentation. There's what we call a technique of lift and shave. So lift, you do a cutter, and lift, and then you cut. As you can see here. The next one is bimanual. After lifting and shaving with a small gauge, you can use your chandelier, you can use your needles. Make sure that any technique, bimanual or unimanual, whatever floats your technique can be used. Okay? Again, segmentation and delamination technique, a bimanual chandelier with a gauge 27. If you're for the fellows out here, you can use your gauge 27s from Alcon or in any brand. Segmentation, you have to isolate it, the neovascular pegs, cauterize it, and then peel. You can use your lift and shave technique. And then, caveat, overzealous peeling of tractional membranes may cause iatrogenic break. So this is one video, as you can see here. There. So sometimes, you just convert the iatrogenic break into a relaxing retinectomy, and then remove the tractions. Hemostasis. The main thing is for a diabetic is to prevent it into conversion into a rhegmatogenous shift. For bleeders, you raise down your IOP. You can use your OCTs. You can use silicone oil, as what Dr. Pang has said. You can use it for combined TRDs and with an RRD. And then diathermy. Make sure that you don't have any bleeders post-ops. Tamponade selection, you can use gas versus oil. It depends on what you like. I prefer gas because I don't want to have silicone oil visual loss post-op in your diabetics. Intra-op OCT, it was discovered that you have 30%, a little bit success, but it slows down your surgery. The main goal for diabetic tractional retinal detachment is to relieve traction. And again, for post-op, it was found that intravitreal dexamethasone along with your post-op PPVs reduces inflammation. You have 70% edema resolution in 6 months. Just remember to monitor your IOPs post-op. Again, step by step, removal of your anterior vitreous, laser, wide field. I think I'm the last, so I can just continue first. Give a minute. Remove your membranes, cut the membranes, remove it. Just don't create retinal breaks in these cases. You can wash, and then you place oil. You can place post-op anti-VEGF for these cases. So again, for conclusion, state of play, 95% success rate with the bimanual and anti-VEGF, small gauge vitrectomies. Prepare your patient, again, do prioritize mobility versus reading vision. Next move, do your hybrid cases. And I'm inviting everyone to APVRS in Manila 2025. So there's a wet lab for this. Thank you very much.
Thank you very much, Dr. Carlos, for an excellent talk on a difficult subject. I think what you mentioned, and I think many of us believe, and probably across, I think if you do a diabetic vitrectomy and you have not created any break, nothing, and you have put the retina back and your hyaloid is removed, you don't inject anything, you are the happiest, they'll be the best.
Yes.
The second best will be if you can give just a air tamponade or a shock-tracking gas tamponade. I think once we have used a oil, what you said, I think it's a bad news, because that means we have created a lot of issues and we have not been able to address the issues. And such cases, they tend to proliferate and do very badly. So I think that is what you also mentioned. I'm very happy
Yes.
about that. I think that is what we should aim for. So what you also mentioned, that we could do minimum at time, even segmentation is good enough. You have segmented and left things there rather than creating. I think many of such cases, especially olden time when we were not going with instruments which were more bigger, the segmentation was done very commonly, and such cases also did very well. So
Thank you.
the lesser the complication and create no break, that is what the bottom line remains.
Thank you, sir.
Great, great. Any questions, please? We still have time, or you have a question for any other speaker, it'll be fine. We have a couple of minutes to go, 3 minutes, yeah.
Sir, I wanted to ask, comment on prophylactic barrage on peripheral lattices discovered on routine evaluation, not in a other eye of an RD patient.
You see, I think if you are asking me,
Yes,
prophylactic laser for all lattice degeneration, again, not required, and it is a bad news, because we see worse detachment after that, because it happens posteriorly and the whole flap will come out. And sometimes you see these lattices are so extensive that you're going to laser whole lot of retina, and they also have these little tractional membranes. So I don't think asymptomatic lattice without any holes or other things, even we are not even treating them once they are going even for refractive surgery. But obviously, I mean, once you have a symptomatic or you have a break there which is trying to collect fluid, or you have a family history of retinal detachment and other things or other eye detached, then it's a different story. But treating all lattice, I think there are a lot of studies from olden time. They have followed them up for a long time. We don't need to do that. That is what my take is. I don't know how you feel about, and others here feel.
For lattice degeneration, I always ask the patient, is it symptomatic? If it's asymptomatic, just leave it alone. As if you read the AO guidelines, treat symptomatic cases. Sometimes it's your laser itself that will cause your retinal breaks.
yes. And so, do you stop systemic anticoagulants before doing vitrectomy, especially in diabetic patients?
If the patient is on dialysis, we don't. If the patient is not on dialysis, we tend to stop. Just for the 7 days, and then continue it after vitrectomy.
Most of the time, if they are just on something like aspirin, it's fine. I think most of the time they'll not be. But otherwise, if it can be and it is safer, I think it's a good idea, because, diabetics otherwise bleed a lot. So I think until unless, of course, there is a special situation, as Carlos said. Yes.
Yes, yes. Thank you, sir. Very nice session.
Thank you.
Thank you. Thank you very much. So appreciate that. Yes, please.
My question to Dr. Tariq and the panel is that, do you follow any extra precaution to prevent the PVR in GRT cases, because they'll end up with very high rates of PVR?
During surgery of that is GRT, if PVR is there, we have to address the bands, and what you have to do at first, pre-retinal PVR bands you have to remove, then put PFCL, then you remove the subretinal bands. That is the thing.
And to prevent PVR in post-op period, do you follow anything extra?
No, I didn't follow, but today we have learned that injection methotrexate can be given, so I didn't try that.
I think one of the most important basic principle which you must remember, why PVR happens. That means we have not removed the vitreous or the membranes successfully. We have not been able to do that. In fact, all my life I never did direct silicone oil and PFCL exchange. Why? Because I am very sure once I do a fluid exchange, and under that, I'm doing, that if my retina is not slipping, I have done a good job. You see, that is what additional advantage sometimes, because I felt that was the easier thing to do, direct exchange. But this one used to give me confidence that I have removed everything, it doesn't slip a bit. So that is where, in fact, sometimes we also check ourselves that how good job we have done. If everything is removed, the PVR is not going to happen. So that is very important. If you have a doubt, you can put again triamcinolone, you can try removing it, you can use various maneuver. And as Tariq has shown nicely, there are sometimes these contracted area in the retina you are not able to relieve. Maybe you'll have to, like he also cut a little bit of a portion, it can be done. Sometimes you have to even flip over. You may have something behind which is preventing it and contracting it. You might have to remove that also. So the addressing during surgery, all these issues would prevent PVR. And of course, if you have something recurrent happening, maybe methotrexate, as said, is a safe drug. And since we are using for other conditions also, so that can be used.
For a
Yes.
tip, always divide your pre-op again, intra-op, post-op. Pre-op, most important thing, under-promise, over-deliver. Talk to your patient. You'd have to tell them. Intra-op, talk as Dr. Tariq. And post-op, injection by Philip. So again, pre-op, intra-op, and then post-op. Most important is share time.